Today I am going to discuss about the metabolic derangements. So what acidosis is? That means the pH falls below 7.35. Okay, and what alkalosis is? The pH is more than 7.45. So if the disorder is primarily metabolic, that means metabolic acidosis or metabolic alkalosis, then the primary change will be at the amount of bicarbonate. The primary will be change of bicarbonate, and the compensatory or the secondary will be change of carbon dioxide. This is the basic. Okay. So what causes metabolic acidosis? That means we have there may be 4 causes of metabolic acidosis. One, if the H plus amount, production of H plus is more than that of the excretion. Second, if the bicarbonate loss is more, that means the lost bicarbonate cannot compensate the excess H plus, right? Or thirdly, if the patient ingested acid from the outside. Okay. So first cause, that means if there is increased acid production, H plus production. So what may be the causes of increased acid productions? So there are primarily 2 acid production causes. That means one is lactic acidosis, another one is ketoacidosis. So these are the primary acid increased chance of, there is increased risk of acid production. That means increased H plus due to production of more lactic acidosis, increased H plus due to production of more ketoacids. So lactic acids primarily metabolized from anaerobic metabolism, with the production of anaerobic metabolism. That means, yes, lactic acid we can measure in ABG. Definitely we can measure, but this is the increase of H plus is a surrogate marker of increase of lactic acidosis. So what are the causes of lactic acidosis? That means when the cell is undergoing anaerobic metabolism, right? So that means the cell is suffering from hypoxia. The cell is devoid of blood supply. That means in case of sepsis, in case of septic shock, in these 2 situations, there are less blood supply to cells, there are less oxygen supply to cells. So that makes the cell's area more anaerobic, and from the cell itself there is production of lactic acids. So this is the primary cause of lactic acidosis. And what are the causes of ketoacidosis? You all know the most common cause of ketoacidosis is diabetic ketoacidosis, right? And second one is starvation ketoacidosis. That means during starvation, what happens? There is increased muscle breakdown, which produces more ketoacids. So what are the different ketoacids? Beta hydroxybutyrate and acetoacetate. These are the most common. So beta hydroxybutyrate is the most common one, right? So we can measure it, beta hydroxybutyrate concentration. So this is the causes of increased H plus production. Okay. So now, so that means, next one is, so that increased H plus production can be compensated by the existing bicarbonate anion, right? If the bicarbonate production is adequate or there is no bicarbonate loss. But definitely if there is problem, so bicarbonate primarily absorbed in kidney, right? You all know. So if there is production, if the kidney is damaged, so there is no reabsorption of bicarbonate further. So in one hand there is increased acid production, and in another hand there is less number of reabsorption of bicarbonate in the kidney, right? So that makes the in the cell more acidic because there is nothing to compensate. Okay, so that means in case of kidney disease, chronic kidney disease, if the H plus is H plus production is normal, but HCO3 reabsorption is not there, right? So there may be acidosis. Next, if there is loss of bicarbonate through the stool from the, actually in case of diarrhea, what happens in the diarrhea, if the patient is suffering from diarrhea, then enough amount of bicarbonate is lost from the intestinal secretion, right? So H plus is static, but bicarbonate is lost. So definitely there is acidosis. But here the other, so in this case, in suppose a patient is suffering from diarrhea, so bicarbonate is lost, right? But there is no increase of production of other acids such as lactic acids or keto acids if the patient is not suffering from any other disease, right? In simple diarrhea. So that means the anion gap that measures the unmeasured anion, lactate and keto acids. This is normal because bicarbonate is lost, but the concentration of lactate is normal. The concentration of other anions are normal. So this is called normal anion gap or non-anion gap metabolic acidosis. Okay? And what happens if the patient ingests some acids in a form of salicylic acid, in a form of methanol, ethanol. So these are the poisonings, right? So that means external ingestion of acids make the environment more acidic, and there is actually bicarbonate is, the present bicarbonate is not enough to compensate that excess amount of acid. So that makes the environment acidic. So that is also high anion gap because external acids are coming, right? So this is high anion gap metabolic acidosis. Okay. So now, so this is clear, right? This is clear. What are the mechanisms of metabolic acidosis? What are the causes? So now, regarding the compensation. So metabolic acidosis is compensated by respiratory alkalosis. So there are two mechanisms. One that is occurring very fast within say hours, within 1 to 2 hours. That means there is increased number of H plus concentration in blood, which stimulate directly the respiratory centers. That makes the respiratory centers increases respiratory rate and depth also. That is called as Kussmaul's breathing, right? In case of diabetic ketoacidosis, that is due to the direct stimulation of the respiratory central respiratory center by the H plus. That makes the patient more tachypneic, and that result in more CO2 wash out, and that causes respiratory alkalosis, right? But definitely this is not enough in case in compensation of metabolic acidosis, because in another 1 to 2 days, after another 1 to 2 days, when the kidney restores the bicarbonate, when the kidney reabsorption of bicarbonate came back to normal, then the compensation will be normalized. That is why the metabolic compensation occurs fully within 1 to 2 days, whereas the respiratory compensation occurs within 1 to 2 hours, right? So this is the metabolic acidosis and metabolic alkalosis. The reverse will happen. There is decrease of respiratory rate and depth, increase of PCO2 to compensate that. So how to calculate the compensation formula in case of metabolic acidosis? So delta PCO2, the change of PCO2 will be 1.2 into delta bicarbonate. There is another formula that is very long. So this is a short formula. You can use this one or another one, that is PCO2 is equals to 1.5 into bicarbonate, that is a very long formula, into bicarbonate plus 40 plus minus 2. So this is the simpler one, delta PCO2, that means delta, that means the change of PCO2. The change of PCO2 will be 1.2 into change of bicarbonate. Okay, so this is the formula. And definitely if the calculated PCO2, suppose the calculated PCO2 is somewhere around 30, right? But the patient is having PCO2 50. So that means the patient is having metabolic and respiratory acidosis. Along with that, metabolic and respiratory acidosis. In case of a patient, suppose a patient is suffering from diabetic ketoacidosis, along with that the patient is suffering from acute exacerbation of COPD. So definitely this can happen. So in that case, the patient may have additional metabolic and respiratory acidosis side by side. So in case of metabolic alkalosis, the expected PCO2, that means delta PCO2 is 0.7 into delta bicarbonate. And so what are the steps of determining metabolic acidosis? One, that is you should determine the primary disorder, that is metabolic. Second, that is compensatory or not. Third one is the most important. In case of all metabolic acidosis, you have to calculate the anion gap. So what is anion gap? The name itself suggests that, anion gap. So the unmeasured anion inside the body is termed as anion gap, right? So that I have already mentioned the causes of high anion gap. That means in those cases the anions inside the body is increased, right? So suppose the patient is suffering from diabetic ketoacidosis or lactic acidosis. These are the anions. So this is increased. So there is an anion gap. So anion gap is calculated as sodium. Actually the ideal formula should be the measured cations minus measured anions, right? So what are the measured cations? Sodium and potassium, but the fraction of the amount of potassium is very low. So that's why we can omit the potassium. That means measured cation, that is sodium, minus measured anion, that means chloride plus bicarbonate. So this is the formula, sodium minus chloride plus bicarbonate. This is the anion gap, right? So this is normally 10 to 14. So if the anion gap is less than 12, this is called as non-anion gap or normal anion gap metabolic acidosis. If it is more than 14, then this is called as high anion gap metabolic acidosis, right? So there is another anion that is called as there is very important one but cannot be measured. The fraction is very low. There is albumin. So suppose a patient is suffering from hypoalbuminemia along with sepsis, right? So you are not measuring the albumin part, then this can be misjudged. The anion gap may be falsely low or high, right? If you are not taking into account the number of albumin in case of hypoalbuminemia. So the corrected anion gap or CAG is anion gap plus 4 minus albumin into 2.5. This is the corrected anion gap. But you need not to do in all cases. If the albumin level is provided in your question paper, or if you are seeing a patient with hypoalbuminemia, that means the patient is suffering from nephrotic syndrome or chronic liver disease, that means the albumin level is very low. So in that case, you should measure the corrected anion gap, not in all cases. So now, if the anion gap is more than normal, more than 12, so what may be the causes of high anion gap metabolic acidosis? As I have already mentioned, that is DK, diabetic ketoacidosis, any type of ketoacidosis. Next, lactic acidosis, methanol poisoning, ethanol poisoning, salicylate overdose. So there is a mnemonic called MUDPILES. You should remember that. So in my next slide, I am about to discuss this the causes of different types of acidosis. So MUDPILES is a mnemonic, right? So in all these cases, in all these high anion gap metabolic acidosis cases, এরকমও তো হতে পারে in some cases of metabolic acidosis there is coexisting metabolic alkalosis with the metabolic acidosis one. Suppose, so what are the causes of, if you are having any idea about causes of non-anion gap metabolic acidosis? So this is the high anion gap I have already discussed about. So non-anion gap এক্ষুনি বললাম, the most common is diarrhea. So in case of diarrhea there is excretion of bicarbonate through the stool and the anion gap is normal. So this is non-anion gap or normal anion gap metabolic acidosis. So suppose if a patient suffering from diabetic ketoacidosis along with diarrhea, the patient is having diarrhea, so that means there may be presence of hagma and nagma, right? Along with the two acidosis definitely can be present altogether. So this is a difficult part. This is a very difficult part, but delta anion gap is very important. So and delta anion gap is very important for your MCQ also. Okay. So what is delta anion gap? When we measure if any other type of acidosis, that means along with hagma there is nagma present or not, or just the high anion gap metabolic acidosis. So this is the measurement of, by measurement can be done by delta anion gap. Okay. So what is delta anion gap? So calculate the delta anion gap, that means delta anion gap divided by ratio. You have to calculate the ratio. Delta anion gap divided by delta bicarbonate. That means delta anion gap. Suppose the anion gap, the calculated anion gap is 20. Okay. So the delta anion gap, that means 20 minus 12. Normal is 12. So the delta, that means change of anion gap is 8. And the bicarbonate is suppose 14. Okay. So the delta bicarbonate is 24 minus 14. 10. Understood? So delta is a change. So the ratio you have to calculate. The ratio of delta Ag by delta bicarbonate. Okay. So in that case, what will be the delta ratio? Suppose anion gap is 12, anion gap is 20 and bicarbonate is 12. So what will be the delta ratio? Anion gap is 20, that means 8 is the delta and bicarbonate is 12. So 8 by 12. This is the delta ratio. Right? So that means 8 by 12, that means 2 by 3. So 0.6, 0.6. So 0.6 is the delta ratio. So this is the, if the patient is having delta ratio of within 0.4 to 0.8, that means mixed acidosis, hagma plus nagma is present. High anion gap along with the non-anion gap metabolic acidosis is present. And if the delta gap is more than 0.8, then this is a case of pure high anion gap metabolic acidosis. So this is clear. This is difficult one, but this is very important. Okay. So আরেকটা অপশন আছে ক্যালকুলেট ডেল্টা গ্যাপ, বাট এটা খুব দরকার নেই, জাস্ট রিমাইন্ড অ্যাবাউট দ্য ডেল্টা রেশিও. ওকে, জাস্ট ডেল্টা রেশিও. So this is the example. Suppose a patient is suffering from metabolic acidosis with এখানে দেখবি না, আমি বলছি শোন, কারণ এটা অ্যান্সার লেখা আছে, জাস্ট শোন. Sodium is 140, chloride is 100 and bicarbonate is 10. So calculate the anion gap. What is the anion gap? 140 sodium minus 100 plus 10. So that means 30 is the anion gap, right? So this is definitely high anion gap metabolic acidosis. Okay. So now calculate the delta gap. Bicarbonate is 10 and the anion gap is 30. So the delta gap will be বল কত আসছে 18 by 14, 10 নয় তো 14 তো 18 by 14, that means around 1.24. So that means this is more than 0.8, 1.24 আসছে তো, so this is more than 0.8, so this is a case of pure high anion gap metabolic acidosis. Now see the example. The anion gap is, suppose the anion gap is 24 and bicarbonate is 8. Calculate 24 and bicarbonate is 8. Delta gap, what will be the delta gap? 12 by 16 to 12 by 16 around 0.75. 0.75. So this is less than 0.8. That means this is a yes, mixed HAGMA plus NAGMA, right? So the patient is suffering from DKA with diarrhea. That means due to DKA there is high anion gap, and due to diarrhea there is normal anion gap metabolic acidosis. And this is, calculate this, anion gap is 36, bicarbonate is 18. কি করে হতে পারে এটা দেখ, মানে বেসিক কি করে বলছে, বেসিক্যালি anion gap is too high, right? And the bicarbonate তো এতটাও বেশি লো নয়, 18 is not that much low, right? So the gap is only 6. So to make anion gap as high as 36, the bicarbonate should be around below 10 or 12, right? So this is 18. That means so when we calculate anion gap, what is the formula of anion gap? Sodium minus chloride plus bicarbonate. So definitely in this case there is hyperchloremia, right? So if the chloride level also is not compensated, then there is only the bicarbonate cannot match the anion gap, right? So there is that is why this is more. Okay, so that means, so this is what is the delta anion gap is 4, right? So more than, see that chart, more than 2 delta gap, that means the patient is having high anion gap metabolic acidosis plus metabolic alkalosis. That means the patient is having hyperchloremic metabolic alkalosis. That means the patient is suffering from diabetic ketoacidosis and vomiting. Vomiting causes hyperchloremic metabolic alkalosis. Clear? So these are the complex one and advanced ABG analysis, but I think this is clear, right? Okay, so these are the causes of high anion gap metabolic acidosis. This is the mnemonic: MUDPILES, methanol, uremia, diabetic ketoacidosis. So these are the causes of high anion gap metabolic acidosis, and this is the causes of non-anion gap metabolic acidosis: ureterosigmoidoscopy, renal tubular acidosis, and diarrhea. These are the commonest. Okay, so why so diarrhea যেটা আমি explain করলাম, so why in diarrhea there is non-anion gap metabolic acidosis? Because there is loss of intestinal bicarbonate. Okay, so why renal tubular acidosis? So there are 4 types of RTA, right? So just one example, in case of proximal RTA, what happens? There is less reabsorption of bicarbonate, right? So during there is the total acid concentration is normal, okay, but there is deficient bicarbonate reabsorption at the proximal part of the nephron. So that means the system is acidic, but anion gap is normal. So this is why in RT, renal tubular acidosis, then there is non-anion gap metabolic acidosis. And these are the causes of metabolic alkalosis. So now regarding metabolic alkalosis, so just opposite to that of metabolic acidosis. Primarily there is loss of H plus, right? And secondarily there should be ingestion of alkali from outside. So what are the causes of loss of H plus? H plus predominantly produces inside the stomach, right? So HCl, H plus and Cl minus. So if the patient is having vigorous vomiting, H plus will be lost via GI tract, or the patient is having NG tube, nasogastric tube and nasogastric suction, then the excess acid produced in the stomach will be removed by the nasogastric suction. So that induces metabolic alkalosis. First cause. So second cause, what will be the second cause? That means there may be H plus loss, more H plus loss through the urine, okay, or GI loss itself. That means that is vomiting in case of GI loss, and in case of urinary loss of H plus. What are the causes of urinary loss of H plus and potassium? There is primary hyperaldosteronism, Cone syndrome. In Cone syndrome, there is loss of renal H plus and K plus potassium. So that means the patient is having metabolic alkalosis along with hypokalemia in Cone syndrome. And the third cause is if the patient is ingesting alkali, antacids, right? So that can cause also metabolic alkalosis, right? And another one is, so renal cause, renal elimination of H plus. One is Cone syndrome and second one is diuretic use. If the patient is using loop diuretics or thiazide diuretic, then H plus will be lost, right, via kidney. So these are the causes of metabolic alkalosis. But in case of gastric fluid loss, so in case of all metabolic alkalosis, we should measure the urine chloride. If urine chloride level is less than 20, the amount is less than 20. Urine chloride is less than 20. That means the chloride is lost via the GI tract, not from the urine. Right? So what are the GI causes of loss of chloride? Vomiting, post-diuretic therapy, right? So these are the causes. So in all cases of metabolic alkalosis, you have to measure the urine chloride. Why? Because if the urine chloride is less than 20, so you should suspect this is a GI loss and you can give normal saline, NaCl, sodium chloride. This is NaCl responsive. If urine chloride is less than 20, that means the alkalosis is sodium chloride responsive alkalosis. If you give sodium chloride, then it will be reversed, or normal saline, then it will be reversed, right? And vice versa, if the urine chlorine is more than 20, then the loss is definitely by the urine, and this is not responsible to NaCl, right? So this is the concept of urine anion gap. So the negative, so what is urine anion gap? And another one, this is very important. What is urine anion gap? So in all cases of non-anion gap metabolic acidosis, you have to calculate urine anion gap. So urine sodium plus potassium minus chloride. In urine you cannot measure the bicarbonate. Okay, so urine sodium plus potassium minus chloride. This is urine anion gap. So if the urine anion gap, so there are different causes of, what are the causes of non-anion gap metabolic acidosis? Just mention 3 causes. One is diarrhea, another one is RTA. These are the most common causes, right? So one is GI loss and another one is renal problem, renal issue. How to differentiate whether this is a GI loss or this is a RTA? This is where you should calculate urine anion gap, right? Because if the kidney is problematic, then not only bicarbonate, but definitely bicarbonate reabsorption will hamper, right? Side by side, there is also problem in excretion of ammonia, right? Because ammonia also primarily excreted through the urine, right? And in case of with the Cl, one NH4 plus Cl minus, ammonium chloride, right? So you cannot measure ammonia. So this is a surrogate marker. You can use chloride. So if the urine anion gap is normal, that means negative, less than 20, that means the kidney excretes large amount of ammonia. Right? Negative, that means sodium plus potassium minus chloride, that means the chloride is higher. তাহলেই তো নেগেটিভ হবে, সোডিয়াম পটাশিয়াম যদি নরমাল থাকে বা ক্লোরাইড হায়ার থাকে তখনই তো নেগেটিভ হবে ইউরিন আয়রন গ্যাপ। ক্লিয়ার? খুব ডিফিকাল্ট এটা, কিন্তু এটা বুঝতে পারছিস? সাপোজ সোডিয়াম পটাশিয়াম ইজ নরমাল প্লাস ক্লোরাইড and chloride is higher level, that means the gap is negative, will be negative. কখন ক্লোরাইড হায়ার লেভেল হবে? যখন কিডনি এক্সক্রিট করবে amount of NH4, more amount of NH4 plus Cl minus, তখনই তো ইউরিনে ক্লোরাইড বেশি আসবে, রাইট? ক্লিয়ার এটা? ইউরিনে ক্লোরাইড কখন বেশি আসবে? যখন ইউরিন থেকে ক্লোরাইড এক্সক্রিশন হবে ভায়া NH4 plus Cl minus. That means kidney is normal. Kidneys can excrete the NH4 plus and Cl minus. So that means the negative urine anion gap denotes the loss is from the GI tract. And vice versa. If the chloride is not excreting, the chloride level is low, below normal, and the urine anion gap is positive, then the loss is primarily from the problem is in the renal tract, because kidney cannot excrete the chloride and NH4 plus. This is simple. It difficult to understand. এটা খুব ক্লিয়ার হয়েছে? This is very important. Difficult definitely, but যদি আবার কোয়ারি কর, যদি এখান থেকে না বুঝতে পারিস। ক্লিয়ার? এই পার্টটা ক্লিয়ার হয়েছে? More than 7.45, alkalosis. And what is the primary disorder? Metabolic alkalosis, right? So primary is metabolic alkalosis. And compensation, is it compensated or not? Metabolic alkalosis এর ফর্মুলা কি? 0.7 কর, ক্যালকুলেট কর। 0. Delta PCO2 will be 0.7 into delta bicarbonate. So the change of PCO2 will be 15.4. That means 40 plus 15.4. The CO2 will be 40 plus 15.4. That means around 55. So এখানে কত আছে? 55 ই আছে, right? So this is compensated. This is compensated metabolic alkalosis. So in all case of metabolic alkalosis, what should we do? We should measure the urine chlorine. So here the urine chloride level is 30. Okay? So this is wrongly written. This is not fluid responsive. If it is less than, this is mistaken. If it is less than 20, this is fluid responsive, right? And this one is compensated or not? The primary disorder, is প্রাইমারি ডিসঅর্ডার কি? Metabolic alkalosis, right? And the compensation? Calculate kor. Bicarbonate is 54. Calculate the delta PCO2. আমার মনে হচ্ছে 0.7 into delta bicarbonate, so that means 21 এরকম আসার উচিত, হ্যাঁ 21 আসবে তো, so delta PCO2 will be 40 plus 21 61, but here the PCO2 is 80, so that means there is another respiratory, along with the compensation there is overcompensation, there is another respiratory acidosis. Suppose the patient is suffering from acute exacerbation of COPD along with the metabolic alkalosis, so the CO2 will be higher than that of the compensatory part. So there is another respiratory acidosis. Okay, so this is metabolic acidosis, right? তারপরে কি করতে হবে? metabolic acidosis বললে তো হবে না, compensated or not, compensated or not, calculate kor 1.2 into delta bicarbonate, so bicarbonate change কত হয়েছে এখানে 12, so 12 is the change, 1.2 into 12 that means 14.4, তাই তো? তাহলে PCO2 কত কমতে হবে? কমবে তো, রেসপিরেটরি অ্যালকোহলিস হবে তো, so 40 minus 14.4 26 25.6 এরকম হবে, কত আছে 40, so this is not compensated, because to compensate that metabolic acidosis the PCO2 should be below 25, তাই তো? So this is not compensated, this is not non-compensated acute metabolic acidosis, right? The next thing is whether you should calculate the anion gap, measure the anion gap, কত আসছে anion gap দেখ, sodium plus chloride minus bicarbonate 130 minus 112 18 is the anion gap, right? 18 is the anion gap, so this is more than 14, so this is high anion gap metabolic acidosis, so this is high anion gap acute metabolic acidosis that is uncompensated or not non-compensated, right? So now the delta gap, what is the delta gap or delta ratio rather, কত আসছে 1.5, so that is more than 0.8, the pure disorder is only high anion gap, so this is a case of high anion gap metabolic acidosis and the patient is unconscious and the CBG is 550, so what is the diagnosis? This is a case of diabetic ketoacidosis, right? Patient কে না দেখে just by seeing the ABG you can easily understand that what the patient may have, right? So these are the questions of recent NEET PG 2025. Calculate করতে পারবি pH, what is the diagnosis? Last NEET PG এর question এটা 2025. The primary disorder is respiratory, কোথায় arrow তো same, 40 to 45 হচ্ছে normal level of PCO2, the PCO2 is almost normal and the primary disorder is same arrow তো, pH কমছে bicarb কমছে, metabolic acidosis, তারপরে দেখ তারপরে কি আছে compensated or not, দেখ compensated হয়েছে কিনা দেখ, 1.2 into delta bicarbonate cord 16 1.2 into 8 9.6 9.6 তো, তাহলে চেঞ্জ অফ PCO2 will be minus 9.6. So 40 minus 9.6, that means 30.4 around হবে। তো এটা হয়নি তো, this is the PCO2 is 44. So this is not non-compensated, acute, and this is high anion gap or normal anion gap? High anion, calculate করেছিস? So this is high anion gap metabolic acidosis. Okay, so এরকম একটা question ছিল, the answer is DK. ওখানে কোশ্চেনটা যেটা ছিল DK ছিল answer. And another one, this one. The primary disorder is respiratory. This is respiratory acidosis. Compensated or not? ভুলে গেছিস তো, ফর্মুলা ভুলে গেছিস? Acute or chronic. Identify whether it is acute or chronic. 0.08 or 0.03 দিয়ে ম্যাচ করছে, দেখ কত আসছে এটা। pH ম্যাচ করতে হবে তো, তবে তুই acute বা chronic বলবি। সেটা কত? হ্যাঁ 2 minus মানে 7.4 minus 2 আসবে। তো that is near to 7.2. That means that is acute, right? So in case of acute respiratory acidosis, what will be the formula? Change of bicarbonate. In every 10 increase of PCO2, the change of bicarbonate will be 1, right? So এখানে কত চেঞ্জ হয়েছে PCO2? 40, 66 minus 40, that means 26. The bicarbonate change will be 2.6. So the 24 minus or plus? Bicarbonate কি হবে, plus or minus? Plus. Metabolic alkalosis দিয়ে compensate করবে তো। So the bicarbonate level will be 24 plus 2.6, that means 26. So here this is 24. So this is acute uncompensated respiratory acidosis. ঠিক আছে? So now just a brief introduction about DK, diabetic ketoacidosis. হয়েছে, মানে পড়েছিস diabetic ketoacidosis ক্লাস হয়েছে? Hyperglycemic emergencies class হয়নি? There are two hyperglycemic emergencies. One is DK, that is diabetic ketoacidosis, and another one is hyperosmolar hyperglycemic state, right? HHS, which was previously termed as HONK, hyperosmolar non-ketotic state, right? So DK, that means diabetic ketoacidosis. There are three terminology. One is diabetes, definitely the patient should have diabetes, right? That means the CBG should be more than 200. Keto, that means the measured ketone bodies are at the higher level, more than 3 if you can measure beta hydroxybutyrate concentration. And lastly acidosis, the pH will be less than 7.35 and the bicarbonate will be less than 15. So this is the definition of diabetic ketoacidosis. This is as per the recent ADA 2025 guideline recommendation, right? And what is HHS? So the previous name itself suggests that this is non-ketotic state. That means there may be no acidosis, may be no ketosis, just the hyperglycemia is there. The sugar level, CBG level is more than 600, 660, okay, and there is ketone body is normal and the pH is also normal. There is severe dehydration. So this is HHS. Can you name one condition where there is the sugar level is normal but there is decay? Very good. SGLT2 inhibitor. Patient is taking the SGLT2 inhibitors and the patient is having diabetes. Then the glycemia, that means the sugar level is normal, but the patient is more to develop ketoacidosis. So this is called euglycemic decay. So this is the classification according to the severity of decay, right? So mild, moderate or severe decay. The glucose level will be same in throughout all the stages of decay. There is more than 200. Previously it was more than 250. Now the cutoff has came, the decay, in case of all decays, the level of sugar will be 200, more than 200. And the ketone body, if the ketone body level is more than 6 millimole, then this is termed as severe diabetic ketoacidosis. And definitely the pH is less than 7.0, then this is also termed as severe decay, right? So these are the, I am not about to discuss this in my slide, because তোদের একটা আলাদা ক্লাস হবে বোধহয় এর জন্য, emergency management or diabetes or endocrinology, সেখানে কিন্তু ডিটেলসে ডিকে পড়ানো হবে, ঠিক আছে? So the primary management of decay or HHS is giving IV fluids. This is the primary management. Okay. Along with that, start insulin infusion, because if the cells are dehydrated, if the cells are not getting enough fluid, then insulin cannot reach the peripheral cells, right? So that means the primary target is to hydrate the cell by giving fluid. Then start insulin infusions accordingly and titrate down. And we all know that insulin causes hypokalemia. In all cases of decay, if you are prescribing, if you are giving insulin, then with each bottle of sodium chloride or fluid, you should administer potassium if the potassium level is less than 3.5. Okay. So this is the brief management. This is the new guideline, 2025 ADA guideline. Okay. So this is the end of my ABG lecture. Any query from your ABG class?